Welcome everybody to the Pathologist Echo. Today we're very excited to have a brief presentation from Dr. Andrew Bellizzi, who's a professor of pathology at the University of Iowa and the immediate past president of the College of American Pathologists Immunohistochemistry Committee. He's going to be talking about tumors of unknown origin and how to use immunohistochemistry. And that'll be followed by Dr. Robert Lukandi from Makerere University in Uganda, who has a very interesting case to show us and discuss with us, which has some unknown bits to it, so it'll be very exciting. On the line, we have about 20 people, and just passing through them, we are mostly practicing pathologists, a couple of trainees, and there are some lab pros that also join. So it's a mixed bag of people. We also have a large contingent of cytologists that sometimes join us, who are our co-group from Africa Calls. But in general, there usually are between sort of 20 to 60, sometimes up to 100 people that will join. And then these are recorded, and many people watch them, the recordings afterwards, just because of the time zone differences. So with that, Andrew, do you have any slides?
Sure.
Okay, so if you want to go ahead and share your slides, we'll let you get started.
Sure.
Great. So I'm going to turn it over to Dr. Bellizzi. Go ahead.
Good morning, Dan. Thanks for the introduction and thanks for inviting me. Robert, it's nice to begin to interact. I'm very interested in your case. It's always an honor and a privilege to speak on this topic, which is near and dear to my heart. I love solving puzzles, and most cases we can do with a good H&E, but there are tumors that are morphologically ambiguous, and we're uncertain as to what I refer to as the broad tumor class. And then among carcinomas, and especially adenocarcinomas, it's desirable to identify the site of origin, which informs therapy. And I'll present a brief approach. Please, I'll highlight, please reach out to me. Feel free to email me, or if you're on Twitter, connect with me on Twitter. I'm here to serve you guys and your patients. What I want you to remember is that we're going to use epidemiology and morphology hand in hand. When I look at a case like this, I generate a differential diagnosis before I even look at the slide based on the epidemiology of disease. And then I use morphology and I generate a second differential diagnosis. And ideally, I try to marry those differential diagnoses to come up with an immunohistochemical panel. I always consider age, gender, and especially the anatomic location of disease. The differential will be different for a tumor presenting in the lung or the liver or the brain or somatic soft tissue. And I'll give you some flavor of that in some of these algorithms. People, when they encounter a tumor of uncertain lineage, they tend to forget the primary tumors that might arise at that site of origin, and they jump to metastasis. So I'll encourage you to always consider the primary tumors that might arise at that anatomic location. And then in terms of immunohistochemistry, there are screening markers and differentiation markers, and there are only a few screening markers. And we use the screening markers to assign the broad tumor class. And by the broad tumor class, I mean mainly carcinoma, sarcoma, lymphoma, melanoma, also germ cell tumor, mesothelioma, and paraganglioma pheochromocytoma. And if you could only order one immunohistochemical stain, it would be a well-optimized broad spectrum epithelial marker, for example, keratin 8E1, 8E3, to rule in or out a diagnosis of carcinoma. And the screening markers, it's broad spectrum epithelial marker, CD45 or CD43 for hematolymphoid, S100 or SOX10 for melanoma, and SAL4 or PLAT for germ cell tumor. Everything else is a differentiation marker. And if you're uncertain as to whether it's carcinoma, sarcoma, lymphoma, melanoma, I would just start with these 3 or 4, keratin, CD45, SOX10 or S100, perhaps a SAL4, before launching into a long panel of immunohistochemical markers. I mentioned I use this epidemiology based approach, and I'll briefly mention what the standard workup is in terms of laboratory testing for CUP, carcinoma of unknown primary, talk about therapy and prognosis, and then share with you a few algorithms around CUP. And then I have a very brief case that's very reminiscent of the one that Robert's going to show us. So to inform my IHC differential diagnosis, I have aggregated United States cancer data and have drawn publicly available data through the American Cancer Society and have drawn some conclusions like 80% of all malignant neoplasms in the States are carcinomas, 10% lymphoma, 6% melanoma, 1% sarcoma. Everything else is very rare. Among carcinomas, 80% are adenocarcinoma. Among adenocarcinomas, these are in the States the 10 most common sites of origin: breast, prostate, colorectum, and lung. And I encourage anybody anywhere in the world to take a crack at this to inform your own differential diagnosis. This is a couple screenshots from a project through the World Health Organization called GloboCan, which is the Global Cancer Observatory. It's a aggregation of international cancer registry data. And I was able to visualize that in Uganda, the single most common cancer is uterine cervical cancer. And actually the second most common cancer is Kaposi sarcoma. We encounter those diagnoses in the States, but they're much less common. Breast and prostate cancer, everywhere in the world, breast and prostate cancer are incredibly common in women and men, respectively. One thing that I stumbled upon when I was digging in the weeds, and it's not surprising, in the States, 6% of malignant neoplasms are cutaneous melanomas, and in Uganda, it's only 0.45% of malignant neoplasms. So melanoma is very, very high on my tumor of uncertain lineage differential, and it's probably should be much lower on your tumor of uncertain lineage differential. This is I call these wall hangers. These are work aids. These are tools that I've constructed to help me do my tumor of uncertain lineage work. And this is a table that lists these broad tumor classes: carcinoma, sarcoma, lymphoma, melanoma, mesothelioma, germ cell tumor, parapheo, and then screening markers to use, when to consider these diagnoses in terms of morphology or site of anatomic presentation, or results of an initial screening panel, and then additional confirmatory markers. So for example, CD45 or CD43 for lymphoma, but then if I have what I refer to as a quote unquote triple negative malignant neoplasm, that is, it's negative for a keratin, CD45, and S100 or SOX10, lymphoma actually goes way up in the differential diagnosis, and I have an additional panel here that I would apply. Clinical aspects of CUP, the workup is focused on the most common cancers. So there's basic laboratories. We do imaging of the chest, abdomen, and pelvis. But we focus on gynae cancers and breast cancers in women and prostate cancer in men. The therapy is empiric. It's platinum plus a cytotoxic, and the survival is really bad. median survival of 7 to 10 months. In a tumor of uncertain lineage in a carcinoma of unknown primary, if you're able to make a more specific diagnosis, the oncologist can give a more specific therapy, and the prognosis is still often poor, but better. It's better than 7 to 10 months. And the median 5-year survival is better than 20 to 25%. These are examples of tumors that present as tumors of uncertain lineage or carcinomas of unknown primary that are readily amenable to identification by immunohistochemistry, that have very specific therapies that can be highly effective. And from the clinical perspective, from the medical oncologist perspective, they want something that they can treat. They want to give a more specific therapy than a platinum plus the cytotoxic. So I consider these to be can't miss diagnoses, especially lymphomas. Carcinoma subtyping, when the tumor is poorly differentiated, again, people get lost in the weeds. Every carcinoma is either an adenocarcinoma, a squamous cell carcinoma, a urothelial carcinoma, a neuroendocrine tumor or carcinoma, a sarcomatoid carcinoma, an un- or dedifferentiated carcinoma, and rarely a mixed carcinoma. So that's carcinomas of 1 or 2 or 3 of these types. And here are immunohistochemical markers that I might use to support squamous cell carcinoma or urothelial carcinoma, neuroendocrine tumor or carcinoma. This is an algorithm that I use all the time. It's sort of complementary to the last one. Once I've gotten a carcinoma, I'm trying to decide whether it's a garden variety adenocarcinoma, which is readily recognizable on the H&E. It makes glands or tubules or papillae or mucin. And for this, we'll use this, and it'll be this 2 slides from now, my principal algorithm for adenocarcinoma of unknown primary. Then there's what I refer to as large polygonal cell adenocarcinoma. That's HCC, RCC, adrenal cortical carcinoma. There's also